or Senecot, and laxatives if indicated. And again, I encourage patients to consult with their healthcare provider before initiating any exercise program or pharmacologic management of constipation. Alterations in nutrition, and this is one that's key because it's not always just related to a patient's treatment, but certainly can be disease related. And so anorexia or loss of appetite certainly is one of the key things that we see in eating changes in patients, but certainly altered taste, and this can be because of some of the medications that they're taking, mucositis or mouth sores or inflammation of the lining, and again, this can be related to medications that patients are prescribed for their treatment. Alterations in GI function, and this can be nausea and vomiting. That may cause some problems that patients don't want to eat. And certainly metabolic abnormalities such as high glucose levels, etc., can cause alterations. So what do? The first thing that I like to do as a baseline assessment in any patient that walks through our door is really to get a nutrition consult, and it doesn't hurt. Just to at least have a baseline assessment from the nutritionist to find out what patients' baseline, what are their goals and what do they want to accomplish, not only what we would like to see, but what the patient wants to see. Frequent small meals, which is what the nutritionist and patients that have symptoms of what we call early satiety, so they eat small portions. They're only able to tolerate small portions. I usually encourage 6 small frequent meals a day, and it doesn't have to be something that they cook, but certainly something that's just a healthy snack. Good oral hygiene, creating a pleasant setting for eating, eating foods that are high in protein and calories, and we hear that a lot, and we hear about the role of protein and what it plays in a patient's fight against cancer, but I cannot stress enough too is that a fiber that's just strictly, a diet that's, just strictly in protein can cause issues too if you forget that you need carbohydrates to fuel energy. And certainly there are appetite stimulating medicines that can be prescribed, that I have prescribed before in certain patients that just truly lack a desire to eat. Depression, I'm sure, will be covered in the next lecture, but certainly some degree of sadness is typically expected, and so what you have to do as a medical provider is really sort through the distinguishing sadness or a mood disorder from a clinical depression. It is treatable. There are multiple interventions that one could use, and we'll talk about some of them in treating depression, but certainly identifying support systems, getting family members and other caregivers involved, as well as other members of, again, the multidisciplinary team, the psychologists, the psychiatrists, and the social workers are key. So what are the signs of depression that we typically look at is the feeling of being sad or just an empty mood. One may report that they have a loss of interest in their ordinary activities. Fatigue, again, can be an underlying sign of depression, so you really have to sort through that when you're interviewing a patient or taking a good history. Sleep pattern disturbances, patients just can't sleep, and it's not uncommon that I will hear that they're not sleeping well at nighttime, or they're active during the daytime and they're lying in bed at night, and that's when the mind starts going in 100 different directions. And so that really can be a manifestation of fatigue itself. Excessive crying, obviously, and chronic unexplained aches and pains. So what do we do, and what are some of the interventions? Certainly trying to report it if you can identify, and it's not always easily identified by a patient, and they will actually often report that they're not depressed, but certainly trying to sort through if you can verbalize some of the symptoms that you are. Alcoholic beverages, although most in this room probably don't sit and drink a whole lot, but it is an offender of not only causing depression issues because it is a depressant, but it can actually cause sleep pattern disturbances. So again, it's another thing that you have to examine when you're looking at it. Participation in support groups is important. It depends, because some patients don't do well in groups and do well in one-on-one connections. So you have to assess, again, as a medical provider, looking at your patient's abilities, that whether the support groups will actually cause more harm than good. There are different forms, and so some patients may not have access to support groups. So there's online chat rooms, and again, I use caution with that because each, again, individual patient's journey is unique. And so sometimes chat rooms and online conversations can actually cause more anxiety and more depression. And certainly offering a supportive atmosphere and the use of prayer or spiritual support can often add comfort. Sleep pattern disturbance is a frequent problem for cancer patients. There's many, many causes. Again, we've alluded to in some of our discussions earlier. In this talk, most of these symptoms almost link together in one way or another, but certainly physical illness can cause it. If you're not feeling well, that certainly can cause some sleep pattern disturbance. But anxiety, depression, or side effects of medications or treatment. And so when I ask a patient, you have to ask, first of all, do they have trouble falling asleep? Do they have difficulty staying asleep? Or are they just waking up at 3 o'clock in the morning and they can't get back to sleep? And so then you take it one step from there and then try to find out which is the way that we're going to be able to classify it and then look at interventions that may do it. The first one is really just trying to establish a bedtime. And, you know, a lot of us in our busy lives, it's sometimes very, very difficult to say, yeah, I'm going to go to bed at 9 o'clock tonight. But there are other things in even the environment itself, like keeping a television on in the room, really does sometimes more harm than good. Sometimes patients find it comforting if they hear a voice and they can just fall asleep that way, but it often is a problem. So establishing it, setting an alarm clock, or only staying in bed when you really need to stay in bed. So if you wake up in the middle of the night and you're having trouble getting back to sleep, get out of the bed, go sit in a room, read a book, pick up a magazine, or do something besides just lying there, and sometimes that's helpful too. Again, avoiding stimulants. There are certain medications and certainly coffee and caffeine and those kinds of things that can keep people awake. Avoiding the CNS depressants, which we talked about, like alcohol, and certainly other pharmacologic approaches. Anxiety, common, very, very common. And so I reassure patients that depression and anxiety are very common responses to the cancer experience. But poorly controlled anxiety can lead to ineffective coping and can be disruptive to a patient's entire lifestyle. There's two classifications that we look at, both acute and chronic. Interventions, pharmacologic treatment, it may be discussed later. Again, it's individualized, so I did not get into the specific medications that we use to treat anxiety because it really is individualized. Again, I always combine non-pharmacologic treatment to any and all of my symptom management, and that's including patient education, psychotherapy, counseling, support groups, and certainly other multidisciplinary approaches. That's it. Thank you, and welcome to Boston for those who are here for the first time.
Robin, thank you so much. And if you guys will notice, Robin's slides are not included in your packets of information, but if you do want to contact the Caring for Carcinoid Foundation, we're happy to put you in touch with those slides. There was some really, really excellent reference material on those slides that Robin just presented. And now I'd like to introduce Katie Binda. Katie is the director of the HOPES program at the Massachusetts General Hospital Cancer Center, and she can also talk a little bit about the HOPES program.
Thank you, Lauren. Hi. Just trying to think, how do I forward the slides? Do you guys forward them, or you guys forward them? Okay, good, thank you. Hi, welcome. My name's Katie Binda, and I am the director of the HOPES program at the Massachusetts General Hospital Cancer Center. Can I have the next slide, please? I do it? Pardon me? Oh, there. Sorry. I'm a social worker. I'm not a computer expert, so this is why I'm not so good at this stuff. Anyways, my name's Katie Binda, and I'm an oncology social worker, and I am the director of the HOPES program at the Massachusetts General Hospital Cancer Center. And I'll tell you in a second a little bit about HOPES. This presentation is part of the panel of experts. I hesitate to call myself an expert about coping with cancer. I think that you all are the experts, and so hopefully what I'm going to speak about today is going to resonate with some of the strategies that you use to cope with your illness. For me, it's certainly been things that I've learned over my 20 years of being a social worker at Mass General from my patients and their families about how they cope. And certainly their stories and their experiences have taught me much more. And that's actually what I'm going to be sharing with you today. In terms of the HOPES program, basically what HOPES is we formed it 11 years ago. It's a program that focuses on improving the quality and well-being of patients and families living with cancer through free education, support, and wellness services. And so what I'm going to talk about towards the end is a lot about our wellness services, which Robin touched on in terms of acupuncture and massage. What our goal in the HOPES program is to provide services that are readily accessible. Services that are at the bedside, in the clinic environment that you can use when you come in for care, and that they're fully integrated into care. So at Mass General, for example, you'll see acupuncturists practicing side by side with the chemotherapy nurses, or massage therapists in radiation oncology or an inpatient. And that's really sort of how we think about it, as Dr. Clark had alluded to. Part of the care is not just from your medical care and that part of the multidisciplinary team, but as Robin said, it's from your social workers, your nurses, as well as perhaps your acupuncturists, your massage therapists, your music therapists. So are psychosocial needs important? Well, I think that you all would say that coping with your illness is really a big part of living with it. It's not just about the medical information, it's about your spirits, it's about your emotional, your social, your psychological well-being. We think it's important. I'm sure you think it's important. Good news for all of us is that the Institute of Medicine also says it's important. The Institute of Medicine is out of Washington, D.C., is a government organization that really looks at the sort of big issues in healthcare, and they create these great reports. And a number of years ago, they created a report on quality in care, and that's really shifted how we provide care in hospitals, looking at patient safety. 2 years ago, they released a report called Meeting the Psychosocial Needs, Healthcare Needs of Cancer Patients. And it's really talking about caring for the whole patient. And it really helped us now move forward the issue of emotional and social care for patients and families. Takes it to a whole different level. In their report, they looked at hospitals across the country. They talked to patients and families across the country. And what they found was that most people reported that their psychosocial health needs are not well addressed in terms of cancer care. Most people are dissatisfied with the amount of information and the type of information that they get around diagnosis, prognosis, available treatments, but also ways that they can manage their illness and health. And also, patients reported that providers don't get it. They don't understand psychosocial needs in cancer care. They don't consider psychosocial care part of the overall treatment plan, and that they really weren't well aware of resources. So what the IOM then did was they said, you know what, in cancer, we need to have a whole new standard of care. Not only do we have to develop great standards for your medical care, but we need to have a standard of care for your psychosocial health as well. So this is something that should resonate for all of you. As a person diagnosed with cancer, you should expect to have satisfying communication with your doctors, nurses, and others treating your cancer. That those of us who are treating your cancer need to ask you about your needs for information around emotional and social support. And that your team needs to help you carry out a plan that links you to information and the support you need, that coordinates your medical, emotional, and social care. So it's not just about the medical parts, it's about you as a whole person. And then it helps you find ways to manage your illness, your treatments, and your health. So as Robin was talking about, there are a lot of psychosocial aspects to living with a cancer diagnosis. As we all know, there are many emotional and mental health issues. I put ... here because those aren't the only four, as you well know. But most people living with a cancer diagnosis have at some point throughout their illness experienced fear, anxiety, depression, sadness. I could go on. There's anger, frustration. These are very, very, very common issues that people live with. There's a lot of social problems. I mean, we hear about it a lot now in terms of looking at healthcare reform. There are financial issues, there are employment issues, there are insurance issues, lack of social support. You know, people are still, even though they have a cancer diagnosis, are also still having their homes foreclosed upon, are also still losing their jobs, are also still struggling with insurance. So a diagnosis, unfortunately, doesn't protect you from those things as well. And that, as we all know, it doesn't just impact the person living with the illness, it impacts their entire family and social system. So that for everyone, there are changes in routines, there are changes in roles, and there are changes in relationships. You think about, for children of people living with cancer, you know, they're especially sort of thinking about this year right now with school starting, there are changes in roles and routines for those kids as well in terms of when a parent has to come in for treatment or for scans. It impacts everyone. So when you think about this presentation, it would be really nice to have one slide to be able to say, so this is how you cope. And that was one of the questions, was how do you cope with this? It's not easy, and there's no one magic answer. But a while back, Cancer Care, which is an online organization, which I included in my note in one of my slides, created this slide, which I thought really was got it in terms of thinking about what coping is. And it talked about coping, not meaning coping. What coping is really managing a problem. It's not just living with it and accepting it. It's really finding ways to manage the problems that you're facing and finding ways to take control of it. So it's the idea that you can't control the fact that you have cancer, but what you really do have control over is how you react to it and how you live with it. So they talked about this in terms of managing. Coping is managing and understanding what you need to do to live with your problems. Coping's making efforts to bring them under control. And it's also this idea of maintaining a healthy balance of realism and cautious optimism. What coping is not is hopeless acceptance of a problem, that there's nothing that you can do about it, that it's being happy all of the time. You know, we hear a lot about the idea of maintaining a positive attitude. A positive attitude isn't being happy all the time. A positive attitude is really being cautiously optimistic, but also being realistic, and also having your days where you allow yourself to be up, but also allowing yourself to be down. And it's also not this sort of laissez-faire, hands-off attitude that there's nothing I can do about it to overcome my problems. There's a lot that you can do to cope with your experience and help yourselves feel better. So what are some of those things? So I'm a social worker, so that means that I think talking really helps. Talking about your feelings and concerns. And whether you do that, finding professional resources, whether it be a social worker. Many of the cancer centers around the country, including all of them here in Boston, have oncology social workers that are part of the disease centers that they work with. Access those people to help you find ways to cope and better understand your illness. They can also have a lot of training around working with families, so they can help your families cope and manage living with your illness. Psychiatrists and psychologists, as well, as Robin had mentioned. Chaplains are integral in terms of helping provide spiritual support. Almost all of the hospitals now have non-denominational chaplains who are incredibly supportive for patients and families. Finding others who have cancer, whether it be peer matching programs like the Network for Patients and Families at Mass General, whether it be at settings like this where you're with others who are in similar situations, and also, as Robin had mentioned, support groups. And just to put a plug in for support groups, and I've done a support group for a number of years, run a support group for a number of years, and one of the common experiences I found was that people would come to a support group that first time and say, it's not for me. We always encourage people, give it a chance, go back. You know, it is incredibly overwhelming to sit in a room, to hear others sharing their stories and experiences and realize that you're in that room as one of them, and it can be very, very overwhelming. What most people